Okay, this is going to be our next lecture. You'll have to forgive me because number one, this is the third or fourth time that I've narrated this particular lecture because of some technical problems with my audio. So you'll have to bear with me if some things kind of get out of order. I tried to keep all the PowerPoints in order as far as what I was talking about, but since I'm doing this after I've done all the other PowerPoints again, I'm kind of jumbled in my head as to what we've covered. This particular lecture is going to be talking about our junctional rhythms. It's one of our shorter lectures that we'll have. It's just about 40 slides, and we'll be talking about rhythms that arise in the AV junction and around the AV junction. So we'll get into that shortly. I'm going to try this. I'm driving down the turnpike, so hopefully the audio is sufficient. But my thoughts might be kind of scrambled around a little bit because I am driving down the highway. So you'll have to bear with me as we go through that. So let's go ahead and get started. So as I stated, this particular lecture is discussing rhythms and beats that arise in the AV node. So real quick, we'll talk about the anatomy leading up to the AV node. So as you guys should remember, there's one right there. The first, our sinus node is where our pacemaker stimulus is generally going to originate from in the normal human adult. And as the stimulus leaves the sinus node, it travels down the interatrial pathways. And then if you'll remember, those stimuli will all back up, and they have that slowdown period at the AV junction to allow the atria to contract before that stimulus is translated down into the ventricles. So we have this brief slowdown period in the AV node, and that's really the big reason we have this slowdown, is to allow for the atrial contraction to occur, so we don't have simultaneous atrial and ventricular contraction. So you do have three zones of the AV node. You have the transitional cell zone, where that interatrial tissue is actually connecting into the node. You have the compact zone, which we will discuss in a later lecture as a where we do have kind of a cyclic movement of the stimulus through the AV node, and then as it leaves the AV node, it goes down into the bundle of His. And so we're going to talk about the rhythms that arise through both of these through these locations. So whenever the AV node fires, when we do have a stimulus that arises there, we have two things that happen. Generally, and most commonly, we'll have the ventricles depolarize normally. Since the stimulus is occurring above the ventricles and in line with the normal electrical pathway, there shouldn't really be any type of delay in ventricular conduction. So our QRS complex in an AV nodal complex should generally be the same as if we had an SA node stimulus. So there really shouldn't be any change there. But what we also have is the stimulus being translated retrogradely back into the atria. So it's kind of a transverse conduction in the opposite way of what we expect to see. So we do have some changes in what our atrial depolarization looks like. So we'd still get atrial and ventricular depolarization generally, but we're gonna have the atrial depolarization in a reverse fashion. So we'll look for those changes. That's going to help us discern whenever we do have an AV nodal complex. So we can have some different looking P waves and QRS complexes and junctional rhythms. AV junctional rhythms is what that's talking about. Generally, the reason we will have a QRS that looks any different is because of where the P wave falls. So if you look at where our beat or our stimulus is occurring in the AV node, up towards the left side of the screen on our, we have a stimulus that arises in that transitional cell zone. We have an inverted P wave with a very short PR interval. We have this because we're retrogradely conducting the atria. So in a retrograde fashion, the stimulus is actually traveling away from the left leg, and this is in lead 2. So we're traveling against the left leg, which is our positive electrode. And so if it's traveling towards that right arm, it's going to be translated. It's going to be noted as a negative deflection on lead 2 of the ECG. So that's why we have that inverted P wave there. There's a very short or no PR interval because the atria and ventricles are being contracted nearly at the same time because of the location of the focus of where our stimulus is arising. If we have a stimulus that arises in that compact zone, generally we won't even see a P wave. It's going to be buried in the QRS complex, and therefore we won't really note it. It's going to be covered up entirely by ventricular depolarization. So essentially, both atria and ventricular contraction or depolarization is occurring at the same time, and therefore we're not going to note. We'll see the stronger stimulus of the QRS complex, and the P wave will be hidden. We can have a P wave that occurs after the QRS. If it takes longer, if that stimulus has to travel back up through the AV node into the atria to cause depolarization, then it's going to occur after the QRS complex, and that can be noted in the ST segment. So that's something to look out as well. So when we're talking about junctional rhythms, our junctional rhythms are all going to be differentiated by the rate. Really, the rate is the only thing that we need to be concerned about. If we know that the rhythm is junctional in nature, then once we know it's junctional in nature, we're going to be able to look at the rate and determine what that rhythm is. So anything less than 60 beats a minute is going to be a junctional rhythm. Usually we consider 40 to 60. That's about the general going rate for the AV junction or rhythms that arise from there. Anything slower than that, we need to be considering something else, a different rhythm as the cause. An accelerated junctional rhythm, we're going to have the same distinguishing characteristics, except our rate is going to be from 60 to 100 beats a minute, and anything faster than that is going to be junctional tachycardia. We can also have junctional escape complexes. So for whatever reason, if we have a dissociation of the atria and ventricles, or we have a failure of the SA node to fire, what we can see is we do have a junctional escape complex in highlighted red here. So something, it looks like here the P wave fired, but the complex was interrupted, the stimulus was interrupted for whatever reason. If that pause is great enough and no other interatrial tissue decides to take up pacemaker responsibility, then our junctional escape complex, our AV junction, is hopefully going to fire off. And basically what happens here is we have a reminder. So the SA node is reminded of what its responsibilities are, and after that first junctional escape complex, it resumes its duties and takes over pacemaker responsibilities. So this is an example of a single junctional escape complex. If we have at least 3 of these complexes in a row, then that's considered a junctional escape rhythm. So for whatever reason, the the SA node fails to fire, and it continues this. It doesn't resume pacemaker responsibilities. No other pacemaker tissue in the atria takes up pacemaker responsibilities. So the AV junction tissue there takes up pacemaker responsibilities. So if there's greater than 3 complexes, we do have a junctional escape rhythm, and the rate is generally going to be between 40 and 60 beats a minute. So recognizing junctional rhythms, like we said, our rate is going to be between 40 and 60 beats a minute. It should be regular. We'll either have absent or inverted P waves, and they're going to be abnormal in some fashion, either hidden or not present. We're not going to have a P to QRS ratio because generally we're not going to see a P wave. The PR interval is not applicable. QRS width should be normal, and there's not going to be any grouping or drop beats. So our differential for junctional rhythm is going to be, some type of SA node dysfunction or atrioventricular dissociation. It can be caused by increased parasympathetic activity. If you'll remember, the parasympathetic part of our autonomic nervous system only innervates to the atria. So if we have increased parasympathetic tone, our atria will be affected, and but our AV junction will not. So that's where we would expect our first escape rhythm to arise in a parasympathetic overload. Also, there's a lot of drugs, myocardial ischemia, sick sinus syndrome, and then electrolyte derangement, and it can be idiopathic as well. We can also have a premature junctional contraction. This is going to be a junctional complex that occurs sooner than expected. Basically the same thing as a junctional escape complex, but it occurs when it wasn't supposed to. That's kind of the way to think about those. An escape complex is necessary because it occurs later than the previous R to R interval, and it's there to remind of pacemaker responsibilities to the guy above him. Premature complexes are the opposite. They occur before they're expected to. In the AV junction, they're increased, or they're going to be caused by increased automaticity. It's an early complex, and it can either have a compensatory or non-compensatory pause, depending on the location and depending on whether it depolarizes the SA node. These can be single events, or they can be, in combination with others as well. Here's our example of a PJC. It looks like a fairly normal QRS complex and T wave. The recognition is noted that we don't have a P wave, so that's going to be our biggest recognition of that. Anytime we have a narrow QRS complex with no P wave or an inverted P wave, we need to be thinking junctional. So whenever we're trying to determine if it's a PAC or a PJC, we need to look at the morphological variation in the preceding T wave, and then we need to look at the pauses and look for inverted P waves with short PR intervals. So what we're talking about here. So why do we need to look for a morphological change in the preceding T wave? If you look at our example here, on the bottom selection we have 3 complexes with a pretty normal T wave or repolarization wave, and then we look at that second complex with the raised T wave, and we can say that that's more than likely a buried P wave located in that T wave. And so if we look at that preceding T wave and we see that variation in morphology, generally that's going to be caused by a PAC, because that's a P wave being buried in that T wave. Whereas on the top, we're looking for any P wave or inverted P wave. We don't see that, and we still have a narrow complex, so it's pretty easy to say that this is a PJC because there is no P wave noted there. So recognizing a PJC, generally they're going to be single events. They can be regular, they can be unifocal or bifocal, they can be bigeminal or trigeminal as well. The P wave morphology is going to be variable. and then there's not going to be any grouping or drop beats. The QRS width should be normal, and the PR interval, if present, is going to be very short, and the P wave inverted if it's present as well. Again, these can be caused by a lot of things. Most people have PJCs on a fairly semi-regular basis. Most of the time they're going to be idiopathic, but there can be some causes for them as well. Accelerated junctional. Anytime the rhythm rate is above 60 but below 100, it's going to be an accelerated junctional rhythm. Anything above 100, generally to about 150, is going to be considered a junctional tachycardia. If the rate is exceeding 150 beats per minute, generally going to be classified as a SVT or AVNRT, which we will talk about at a later time. So again, here we have our some printed out examples. Anything less than 60 is a junctional rhythm. Accelerated junctional is 60 to 100. Anything greater than 100 is going to be junctional tach. So, as we just stated, the biggest differentiation between junctional rhythm and accelerated junctional is the rate. Accelerated is going to be 60 to 100 beats a minute. And then anything above 100 up to 150 beats a minute is going to be junctional tachycardia. Okay, so at this point we're going to be talking about our supraventricular tachycardias and AV node reentrant tachycardias, what we're talking about when we say that. So just kind of try and take this in, guys. This is some kind of new terminology that's really just starting to catch wind, and not really new. It's been out for about 10 to 15 years, but in the grand scheme of things, still fairly new whenever we're talking about our AV node. So just kind of try and take this in and just get familiar with what we're discussing. But a lot of this is really good stuff to know, but it really doesn't change our treatment modality so much as it is as a comprehension of our mechanisms of what we're dealing with whenever we have a tachycardic patient. So supraventricular tachycardia is really just a categorization of rapid tachycardias, and it's generally utilized when it's difficult to determine what the underlying rhythm is due to the rate. So SVT, the term, really encompasses a lot of different rhythms, including, it could be anything from atrial tachycardia, multifocal atrial tachycardia, or AFib with rapid ventricular response. There's a lot of different rhythms that are considered supraventricular tachycardias. If you break that word down, supra meaning above and ventricles meaning ventricles, basically all this says is that we have a tachycardia that's originating above the ventricles. So there's still a lot of stuff there where there's still a lot of anatomy where this tachycardia could be coming from. SVTs can have either a narrow or wide complex. This makes it difficult to determine sometimes what type of tachycardia we're dealing with. So if we have a wide complex tachycardia, that it can make it difficult to determine if this is a ventricular tachycardia or what we call an SVT with aberrancy. So underlying rhythms in SVT can be anything from one-to-one flutter, uncontrolled AFib, junctional tachycardia. There's a lot of different ones. So AVNRT is standing for AV nodal reentrant tachycardia, and AVRT stands for atrioventricular reentry tachycardia. These are terms that are used more accurately to describe what the underlying cause of a rapid tachycardia is. So unfortunately, most of the time in the pre-hospital setting, our interpretation is generally going to be SVT, but we need to be familiar with these terms and what we're talking about and what we're really looking at whenever we see a supraventricular tachycardia in the field. So we're going to talk about AVNRT and reentry circuits. And the reason for that is there's a lot of research out there that shows that about 70 to 80% of tachycardias or SVTs are actually AVNRTs. So CNR, for example, multifocal atrial tachycardias, with a rate that's high enough to be considered an SVT is generally pretty rare. Most of the time, AVNRT, a reentry circuit in AVNRT, is going to be the cause of most of our SVTs. So we need to be familiar with what that looks like and what that is. Okay, so here we have a little graphic. What this is an AVNRT reentry circuit. So whenever we look at our AV node, we need to be cognizant of the fact that there are two paths of conduction down the AV node. One of the paths is slow and the other is fast. So every time our heart beats in the normal person, that we have this. What happens is generally we have the fast side that cancels out the slow side. So if you think about it in a circle, our fast side, the stimulus reaches the top of the circle at the same time, and then both of them branch out and are trying to meet up at the bottom. But what happens is our fast side cancels out the slow side because it gets to the bottom first and meets up with that with that slow side and cancels that stimulus out. So the problem is what happens when we have excuse me, something else you need to remember is because the fast side is canceling out that slow side, there can be times where the fast side is in a refractory period longer than the slow side. So if you look at the second picture here, we have a stimulus that is reaching a premature stimulus. So, for example, a PAC occurs, and it comes down and it hits our circle. Our slow side goes around, but our fast side is still in the refractory period due to the fact that it is, the stimulus made it all the way around on this side, and it took longer for that stimulus to reach around because it went around the slow side and continued down into the bundle of His. So it's still in the relative refractory phase, but our slow side is not. So look at our third picture. We have a continuation of our slow side around the circle, and once it gets to the bottom of the circle, it innervates the ventricles, but it also goes back up the fast side. Okay, so after this, the slow side is refractory, but by this point, the fast side isn't. Now, this is what happens is we create a reentry loop. By the time that stimulus gets back around to the slow side, it is no longer refractory. So it becomes a cyclical motion. Once this occurs, it starts into a reentry loop that has to be broken by something. So I know that may be a little hard to comprehend, but this is in essence the simple version of how a reentry loop is created. So we'll talk about that more on the one other thing I will note is that this potential for a reentry circuit is readily available in every healthy person. Healthy people can get SVT or have a tachycardic episode just as easily as a sick person, because the anatomy is set up for this. There's no structural abnormality. Everybody, if you have a PAC that occurs at the exact right time, anybody can have a bout of SVT or a rapid heart rate. So that's important to understand. That's why this is so common. This is the most common form of a supraventricular tachycardia, because it can happen to anybody. So now for a moment we're going to talk about what happens when we have what we'll call an accessory pathway. And it's important to understand. We'll have a slide. It's kind of out of order here, I'm noticing, but there are at times individuals that can be ailed with what's called an accessory pathway, and what this is just an extra bundle of tissue that connects the atria and the ventricles. So That means there's another route for electrical stimulus to travel other than the AV node. So this can cause some significant problems in certain individuals. When this happens, you will have generally two types of conduction, a anterograde conduction and a retrograde conduction. But generally when these people are just sitting around, they're healthy, they have an impulse, the normal impulse travels down the AV node and as well as the accessory pathway. So the impulse traveling down the accessory pathway is going to be a lot slower because it's cell-to-cell transmission. There's no node. There's no AV node. And this makes it what we'll call a delta wave. And I can't remember at this point if we've already discussed this before, but if not, hopefully it'll make a little more sense in a later lecture when we start talking about Wolff, Parkinson, White, and other diseases with accessory pathways present. So you're going to have, in this instance, you'll have a physiologic block. And what we're talking about here, guys, is the AVRT. The last slide we were discussing AVNRT. This is atrioventricular reentrant tachycardia that's discussing whenever you do have the accessory pathway. So the impulse is going to be transmitted through the AV node, and it's conducted faster throughout the ventricles, and then the impulse transmitted through the AV node is going to cancel out the accessory pathway impulse. So you can't have problems with this. So generally, what I'm saying is you have this accessory pathway, but whenever they're not conflicted with the tachycardic symptoms, the pathway is canceled out. The AV node cancels all the stimulus that the accessory pathway tries to produce, so it doesn't really matter. But at times, whenever the stimulus is allowed to conduct through the accessory pathway, it can cause some tachycardic symptoms. So, in AVRT, the accessory pathway is going to begin conduction through the ventricular tissue, and then it's later reset by the AV conduction. There's generally going to be a delta wave, and that's going to be present even when they're not tachycardic. So, this is a distinguishing characteristic that we're going to see in people with diseases such as Wolff, Parkinson, White, LGL, etc. So here we have an example of an accessory pathway in the wall of the left ventricle and left atria. There's an impulse that goes through that pathway, but it's canceled out by the ventricular conduction. But when that impulse is not canceled out, that's when you can have a AVRT reentry circuit that is created. And we'll talk about one of those rhythms where this happens. Alright, so we'll talk about one of those rhythms that does have an accessory pathway. So Wolff, Parkinson, White, characterized by a short PR interval, the presence of a slurred delta wave at the beginning of the QRS. You'll have QRS complexes that are wider than 0.12 seconds. Then you can have ST and T wave abnormalities. WPW syndrome is going to occur when a tachycardia is present, but the signs of WPW are still noticeable even when the patient is not tachycardic. So basically you have two possible reentry circuits that you can have, and that's an orthodromic and an anadromic pathway. So an orthodromic pathway, the impulse is going to pass through the AV node. You have normal ventricular depolarization, and then you have retrograde or backwards conduction through the accessory pathway back to the AV node. So in this situation, you're going to have a narrow QRS complex because the ventricles are depolarized in the normal fashion. In an antidromic conduction or antidromic circuit, the impulse is going to pass through the accessory pathway. You'll have slow cell-to-cell ventricular depolarization, and then you'll have retrograde conduction through the AV node and back to the accessory pathway. So because you have that slow cell-to-cell ventricular conduction, you are going to have a wide QRS complex. But and the biggest thing to remember is that you still have the same reentry circuit as what you would in AV-NRT. What happened was you had a premature complex that occurred at just the right time when in an antidromic circuit. It occurred when the AV node was refractory to stimulus. So the path of least resistance was to go through the accessory pathway and then back to the AV node. By the time that stimulus reaches the AV node, it is no longer refractory, and it is able to continue that stimulus back to the accessory pathway, and then that's when your circuits begin. You have a continuous circuit, and that's the same thing with an orthodromic circuit. Your accessory pathway is refractory whenever when the premature stimulus is provided, but as it passes down through the AV node, reaches through the ventricular tissue and hits that accessory pathway, it's no longer refractory. Thus, is able to accept that stimulus back into the atria without having a new stimulus, and it takes that and back into the AV node, and the circuit is created. Okay, so here we have an example of an orthodromic pathway. You note that you have your premature stimulus, so starting just at the AV node. The stimulus hits the AV node, passes down into the ventricles, depolarizes the ventricles through the normal accelerated fashion as it normally would in a normal complex. And then it hits the accessory pathway, and because that accessory pathway is no longer refractory, it is able to pass through retrograde back to the interatrial tissue, and then the stimulus reaches the AV node again and continues on. And that's an example of a closed circuit, orthodromic circuit, that is the cause of a tachycardia in an individual with an accessory pathway. And we'll talk more about those accessory pathways in a later lecture, about some of the terminology associated with that, and some other problems that can arise from those. All right, we're going to look at some examples here. So remember, as we look through, use your cheat sheet. Make sure you are using your same 4-step method that we've been discussing. All right. First example here. Sorry, I'm driving through traffic, guys. I just made it into Texas, in case anybody cares. So our first example here looks like our rate is 300, 150, 100, about looks like 68 beats a minute. 64 beats a minute or so. We have narrow QRS complexes. Is it regular? It looks regular to me. Narrow QRS complexes. We have no T-wave abnormalities or anything like that, and we do not have any P waves. So this tells us this is going to be an accelerated junctional rhythm. And we're right on that borderline. If it's, I'm having a hard time seeing it. If it's over 60 beats a minute, then we would call it an accelerated junctional. If it's under 60 beats a minute, that'd just be a junctional rhythm. All right, so on this particular example, look down here at lead 2 for our rhythm interpretation. At the very bottom, we have a rate of, looks like about 140 beats a minute. It looks regular. We do have narrow QRS complexes. It looks like there's a secondary T-wave abnormality, but we're not concerned with that for our interpretation purposes. We do have inverted P waves just before the QRS. So we can say that this is a junctional tachycardia with a rate of about 140, 130 beats a minute. due to the inverted P waves, just with a very short PR interval. Okay, here we have a rate of 50 beats a minute. It is regular. Narrow QRS complexes. We do have some notching in the ST segment just past the QRS. So this is an example of a junctional rhythm with the pacemaker focus located very deep in the AV node at the end of the AV node. So it's taken a long time for those stimulus to reach the atrial tissue and depolarize. So our atria are actually depolarizing after our ventricles. All right, our rate is about 150, 140. It looks regular. It's regular. It's got narrow QRS complexes. No T-wave abnormalities noted. And we do have, looks like, some inverted P waves just shy of the QRS. And so this is another example of junctional tachycardia. All right. What's up? Some road work. Huh?
It doesn't look very long.
Let's see, our rate is slow. Looks like it's like let's see, about 30 beats a minute, probably. We have narrow QRS complexes. It is regular. Inverted P waves before the QRS. This is another example of a junctional rhythm. Alright, this is a rate of about 110 with narrow QRS complexes. It's regular. We do have a, looks like a P wave that is notched in there after the QRS complex again. It's another example of junctional tachycardia. Alright, here we have an example of, let's see, a rate of about 180, 190. We have regular rhythm, narrow complexes. Looks like we have inverted T waves before the QRS complexes, but this is a little too fast for it to be a junctional tachycardia. So we're going to call this an SVT. Note the electrical alternans here, with every other QRS being taller than the last. And this is more than likely a AV node reentrant tachycardia. Alright, here we have an example of another, let's see, rate of about 150. We have narrow complexes. It is regular. So that's the rate up on the top there. It says 180. The complexes are regular. They with narrow QRS complexes, and we have no really discernible P waves. We do have a T wave with every QRS. So we're just going to call this a SVT. Without seeing the beginning of when this, when this rhythm SID, it's hard to say if this is an AV NRT or not. It could just be a atrial, a junctional tachycardia with a very high rate. But to be safe, we're just going to call it a SVT. Alright, here we have an example of what we were just talking about a little while ago. We have a regular rate, a regular rhythm, the rate's about 75 beats a minute. Narrow QRS, the QRS complexes are mildly widened. We have a normal P wave with a short PR interval. And but note the very slurred appearance of the QRS complex. That's going to be our delta wave. We have a delta wave that's mostly recognized in our precordial leads in V1, 2, and 3. Note that at the very beginning of the QRS complex, how it's very slurred at the beginning appearance. This is an example of Wolff-Parkinson-White, subtype 1A, if anybody's curious. And we'll talk about those subtypes in a later lecture. Alright, here we have a rate of about we'll say about 60 beats a minute. It's not regular. We do have narrow QRS complexes. We have P waves in front of all our complexes except one right there in the middle. Our fourth complex does not have a P wave. And we have a narrow complex there with the same T wave as the preceding complexes. So due to that pause before this complex, we can say that this is a sinus. Looks like it's probably a sinus bradycardia with a junctional escape beat. So after that junctional escape beat, it looks like our SA node resumes its pacemaker responsibility. Alright, here we have an example of a rate of about 60 beats a minute. It is regular except for the premature beat. And we have narrow QRS complexes. We have a P wave in front of every beat except the second to last beat there. And that second to last beat becomes premature, so we have a sinus rhythm with a premature junctional complex. Alright, this is the end of the PowerPoint on junctional rhythms. So proceed to the quiz on junctional rhythms, and we will meet back at our next lecture. And as always, if you guys have any questions, feel free to contact me, and I will try to help you out, or we will see each other in labs.